This next series of sessions by Drs. Slayton, Oliver, and Dooling, we're going to do in the following manner. So we're going to ask Dr. Slayton to present the modeling, excuse me, let me take this mask off, the modeling allocation strategies, followed then by questions. And then we will group the work group interpretation and prioritization and work group next steps in the next batch. So let's begin with Dr. Slayton and modeling allocation strategies for the initial COVID-19 vaccine supply. Dr. Slayton, please go forward.
Good afternoon, and thank you. Next slide, please. Today I'll be presenting on two models that we've developed. The first looks at a U.S. population stratification, and the second focuses specifically on nursing home-related issues. Next slide, please. Before we dive into the two models, I'd like to outline some considerations for mathematical modeling. Mathematical modeling is an iterative process based upon the best available data at the time models are developed. Models should be updated as new data become available, as sensitivity analyses also enable a systematic exploration of uncertainty. We will describe some initial sensitivity analyses in today's presentation and are interested in the committee's ideas about additional sensitivity analyses that may be beneficial. Next slide, please. We'll start with the U.S. population stratification model. Next slide. I'll take a few minutes to walk you through the methods first. This model is a stratification model based upon data from the National Health Interview Survey from 2016 to 2018. We take self-reported data on age, race, ethnicity, occupation, and medical conditions. The age groups employed in this model are children 0 to 17, adults 18 to 64, and adults greater than or equal to 65 years old. Race and ethnicity groups included non-Hispanic white, non-Hispanic black, Hispanic, and other. Next slide, please. We included a risk status within each age group that was a dichotomous variable which represented individuals having no high-risk medical conditions or greater than or equal to one high-risk medical condition. These conditions came from NHIS self-reported data and included obesity, chronic obstructive pulmonary disease, chronic cancer, weak or failing kidney, chronic heart problems, and chronic diabetes. Additionally, we looked at occupational groups with two priority occupational groups assessed. The first was healthcare personnel, defined as any individual working in a healthcare setting, whether paid or unpaid, and the second priority occupational group included essential workers, comprised of food supply, emergency services, utilities, critical financial services, government, and education. Next slide, please. We modeled a scenario that included a partial reopening and social distancing measures. This included school contacts being reduced by 70% from baseline and workplace contacts being reduced by 50% from baseline for all individuals except healthcare workers and essential workers. In this initial analysis, we looked at two sets of vaccine efficacy assumptions by age group per two-dose course. These are broad assumptions and are not meant to represent any specific product. The first analysis evaluated a 70% VE for persons 18 to 64 and a 50% VE for persons greater than or equal to 65. And the second analysis looked at an assumption of 70% VE for all adults. We assumed prior immunity as stratified by age and depicted here that was derived from seroprevalence surveys in Louisiana from CDC's prior work. Mortality included unadjusted risk ratios by age, race, ethnicity, and risk factors, and were adjusted to model strata using ranking methods. Next slide, please. The model considered the incremental and relative impact of vaccine courses and looked at contact rates among the 72 strata of the model based on age and location-specific contact rates in home, school, workplaces, and other. We employed a deterministic compartmental modeling framework and assessed the estimated incremental impact, which included both direct and indirect benefits. We assessed the impact on population-wide incidence and derived our estimates from the rates of most probable transmission among groups before and after vaccination, or the dominant eigenvectors of these matrices. Next slide, please. For our first analysis, where we assumed VE was 70% among adults 18 to 64 years old and 50% among adults greater than or equal to 65 years old, you'll see the population-wide decrease in rate of COVID-19 infections and COVID-19 deaths per 10 million vaccine courses. You'll note that vaccinating healthcare personnel, essential workers, and individuals with underlying conditions resulted in reductions in both infections and deaths, whereas vaccinating individuals greater than or equal to 65 years old resulted in smaller decreases in COVID-19 infections and larger increases in COVID-19 associated deaths. Next slide, please. In our second analysis, we looked at VE of 70% for all adults and saw similar patterns. Next slide, please. Now we'll transition to looking at the nursing home specific model. Next slide. This model was parameterized to represent a mean nursing home set of characteristics from an analysis of data from the Centers for Medicare and Medicaid Services. This nursing home was comprised of 87 residents with a mean length of stay of 88 days and 41 healthcare personnel who were assumed to work daily in 8-hour shifts. We assumed that healthcare personnel interacted at work with other healthcare personnel and at home and in non-school settings with others in the community. Healthcare personnel were assumed to self-isolate on symptom onset, and prevalence of infection among admitted nursing home residents was assumed to follow the community prevalence. The first dose of vaccine in these analyses was assumed to be given before the introduction of infection into a nursing home. Next slide, please. The product assumptions for these analyses included 2 doses of vaccine given 28 days apart, with protection developing 14 days post-injection. We evaluated a VE variable of 70%, 50%, and 30% among patients 65 and older. And we assume that vaccination does not attenuate severity nor transmissibility of breakthrough infection. We assume no waning of immunity over the analysis time horizon. Next slide, please. This slide depicts a typical outbreak in a nursing home without the introduction of vaccine. Time in days is depicted on the x-axis, and prevalence of infection is depicted on the y-axis. We are providing separate epidemiologic curves for healthcare providers in gold, residents in green, and the community in gray. Next slide, please. When evaluating vaccines with variable VE, as shown on the x-axis here, and grouped by vaccinating either healthcare providers on the left or residents on the right, we estimated that vaccinating nursing home healthcare providers results in greater reductions in both infections and deaths than vaccinating nursing home residents. This is even when assuming that residents are at a higher risk of severe disease and death due to their older age and presence of underlying medical conditions. Next slide, please. In summary, from our two models that we've presented here today, you'll see that vaccinating healthcare personnel, essential workers, or adults with underlying conditions resulted in reductions of COVID-19 infections and deaths, and vaccinating adults greater than or equal to 65 years old resulted in more modest declines in infections and larger declines in deaths. Vaccinating nursing home healthcare personnel resulted in greater reductions in both infections and deaths than vaccinating nursing home residents. Thank you.
Are there any questions? Dr. Hunter.
Thanks for that presentation. I'm wondering, will, with each additional 10 million doses of people vaccinated, according to this modeling, will that reduce infections and deaths another 3 to 4% in a linear fashion, or is there any reason to suspect that there'll be increasing benefits or conversely diminishing returns from vaccinating each additional 10 million people?
So in our initial analyses, we were considering the first allocations of vaccines that would become available, which follow more or less linear patterns. As additional doses are assumed to be part of the scenario, you may deviate from those linear trends, and additional analyses would need to be conducted with better defined parameters on expected VE and seropositivity among vaccinated and unvaccinated individuals to better discern those trends.
Thanks. So you're just giving us information that we can incorporate into a decision about the decisions about the initial vaccination, but the other steps and phases might need additional information to guide those, it sounds like. Did I interpret what you said correctly?
Yes, that's correct. Our
Thank you very much.
intention was to provide data to help with the initial allocation decision.
Thank you.
Dr. Maisonnier has a question or comment.
Yeah, just to, for clarification, Rachel, always excellent presentation. But you're looking at this as the unit of action being an individual getting vaccinated. You didn't model, for example, if vaccination of healthcare workers prevented COVID from entering a facility and therefore would have additional benefits beyond the people that were vaccinated. So I'm not exactly talking about herd immunity, but sort of you didn't evaluate, again, for example, somebody introduced it into the nursing home. If you could prevent that person from getting sick, then in fact there's an indirect benefit for everybody else.
Sure. So our initial analysis of nursing homes was based upon the assumption that there had not been a prior importation into that nursing home. You're exactly right that protecting nursing home residents from those importations, which the models and the epidemiologic data suggest are primarily coming in through their healthcare providers, is important, and that further modeling could be done to discern some of the value that you're describing there.
So if I could offer comment to that also. So while healthcare providers are important sources of introduction of COVID into the nursing home environment, visitation is also an important route and needs to be, and as an added variable to this calculation. So even protection of the nursing home residents by protecting the healthcare providers will still leave a window open for those that come from the public and visit. Dr. Hunter, your hand is still up. Did you have a follow-up question?
Sorry, I neglected to put my hand down again, sorry.
No problem. Just want to make sure. Dr. Atmar.
Sorry, I had that on mute. A beautiful presentation. Thank you. I have two questions. The first, I guess I'll follow up on the nursing home question. Did you model if both what the results would be or the incremental benefit of vaccinating both healthcare personnel and residents?
So it's a linear model, so it would be additive for the VE values that one assumes for residents and healthcare personnel, respectively.
Okay. Thank you. And then for the first model, did you do any sensitivity analysis in terms of what the effect would be if there was a higher seroprevalence in the community?
Yes, we have evaluated some different assumptions about both the level of mitigation and the prior seropositivity. As you would expect, both of these parameters are influential in the absolute magnitude of some of the results. We did not include in this iteration of the model any kind of screening of individuals prior to receiving a vaccine to better represent our understanding of the current trials and strategies that are being considered. But those are added features that we could explore further in this iterative process.
But you wouldn't, although the absolute numbers might change, you wouldn't expect the relative amount of protection to be different than what you observed with the seroprevalence you measured or used?
I think over the parameter space that the current data suggests that we're in, the relative reductions were relatively stable. The longer the timeline for vaccines to become available and the more that we deviate from those initial assumptions, both of prior seropositivity and the level of mitigation and the contact structure that we've employed in the model, the more we would expect that to deviate.
Thank you.
Dr. Szilagyi.
Sorry, I was on mute. Very nice presentation. Sorry about my echo. I was wondering if you could put the two analyses together and estimate what the population-wide impact on death, for example, would be for a nursing home vaccination program. In Los Angeles, for example, it's gotten less now, but 40 to 50% of all deaths were from individuals in long-term care facilities. And do you see what I'm getting at?
Yes, so that's a good question. The nursing home model did not include visitors from the community, as a prior questioner also described. And because older adults, in the best available data that we use to develop these models, have lower number of contacts than younger adults, and because nursing home residents in particular tend to stay in the nursing homes, so that distribution of length of stay is bimodal with short stay and long stay nursing home residents, the impact on the broader community of vaccinating the residents, I would expect to be relatively small. The impact of vaccinating the healthcare providers who may work across multiple nursing homes and tend to be younger adults with higher numbers of contacts in the facilities and in the communities would be somewhat larger.
And my other question was, with the prior data about the very large percentage of hospitalizations, ICU deaths among individuals with underlying conditions, I guess I'm surprised that the percentages, this is slide 10, I'm surprised that the percentages, the population-wide decrease in rate per 10 million courses was so low in vaccinating individuals with underlying conditions with a relatively high VE of 70%.
So the deaths are if you're looking at slide 10, of the population-wide decrease in deaths of vaccinating individuals with underlying conditions is somewhat larger because those are more of those direct effects from vaccinating that age group. The infections, which also includes some of the indirect effects to a greater degree because of the age distribution of individuals with underlying conditions modeled and the assumptions about the numbers of contacts those individuals have with other folks are more similar to the age structure and therefore the reductions in infections of vaccinating healthcare personnel and essential workers.
Thank you.
Dr. Fry, excuse me for jumping over you to Dr. Szilagyi. Dr. Fry, go forward.
Thank you. Very nice presentation, thanks. I had a question about the choice or the assumption of a 70% VE, and I might have missed it, but I was wondering if you were also going to consider a lesser VE of 60% or even 50%. I'm not sure, and I might be wrong about this, but I'm not sure people have completely decided what VE might be an acceptable VE, although we would like to see 70% or 80%, but it may not be that high. And I was just wondering if you had considered that or thank you.
Yes, we've run this analysis with VE values of 50% and 30%, though in the interest of time did not show all of those combinations here. The general trends hold true, looking at the differences across the sort of first three groups vaccinated compared to the third, though the absolute values change as you would expect.
Dr. Maldonado.
Yeah, sorry. I had a question about your indirect effect assumptions. So you may have mentioned this, but did the indirect effects assumptions vary by population, and how did you decide how to vary indirect effect size in your different populations?
So those indirect effects are all coming in from the assumptions we made about the contact structure. We're using age stratified contact rates, which is a common set of assumptions that mechanistic modelers use. And additionally, because we were evaluating the occupational groups of interest, we added an assumption that workplace contacts would be reduced by 50% from baseline for individuals in all occupations except healthcare and essential workers. Those workplace contacts are one of four groups of contacts that we included in the model. The others were home, schools, and other settings.
Dr. Dries.
Yes, thank you. Thank you for a great presentation. My question is about your assumption that healthcare workers stop or they isolate as soon as they become symptomatic. I think our experience and many others is that they continue to work for at least a few days, sometimes longer, with the early symptoms of COVID, sometimes because, often because those symptoms are subtle and are not recognized as COVID until later. And so I would just be curious, I would assume that would accentuate the value of vaccinating healthcare workers, but I was wondering if there was any plan to incorporate that variable into a sensitivity or other analysis. Thank you.
So the initial model includes healthcare workers coming to work while infectious if they're pre-symptomatic or if they are asymptomatic. And from the pandemic planning scenarios, the current set that are on CDC's website, that asymptomatic group is about 40% of the population. And so we do have healthcare providers coming for some period of time during their pre-symptomatic phase and a substantial minority of infections who are asymptomatic for the duration. We can modify these assumptions to show the impact, which you're right, would likely be larger if we have healthcare providers working for a longer time while infectious.
Are there any other questions or comments from the work group? I don't see any, so thank you very, very much, Dr. Slayton, for this presentation and for answering the questions. Now we're going to go on to the next two presentations, starting with Dr. Oliver on work group interpretations.
Thanks and good afternoon. Next slide. So first, for a quick overview of COVID-19 vaccines in human clinical trials. Next slide. This is a list of vaccines in clinical trials that are actively recruiting in the United States. We heard from Moderna and Pfizer today, and both are actively recruiting for phase 3 clinical trials. Next slide. These are the mRNA or DNA vaccines that are actively recruiting outside of the United States. Next slide. These are the protein subunit vaccines that are actively recruiting globally. Novavax recently published phase 1 data from Australia with plans to begin phase 2 studies in the US and Australia soon. Next slide. And these are the viral vector vaccines that are actively recruiting globally. The University of Oxford AstraZeneca vaccine has begun phase 3 trials outside of the US and has plans to begin phase 3 trials in the US soon. Next slide. These are the inactivated vaccines that are actively recruiting globally, and there are several phase 3 trials currently being conducted in China. Next slide. So next I'll show the workgroup interpretation of the clinical trial data. Next slide. So information was reviewed by the workgroup, including both phase 1 immunogenicity and safety data from the 2 mRNA vaccines, and plans for phase 3 studies for both mRNA vaccines. Next slide. This slide shows the immunogenicity and safety data reviewed by the workgroup for mRNA 1273 vaccine. Regarding immunogenicity data, neutralizing and binding antibodies were measured at 7 days post-dose 2, and responses were similar to or exceeded a convalescent sera comparison. A Th1 biased CD4 T-cell response was noted, and based on the phase 1 data, a dose of 100 micrograms was selected for the phase 3 clinical trials. Regarding safety data, local and systemic symptoms were followed for 7 days post-vaccination. Pain, myalgia, and fatigue were the most common symptoms reported. Reactogenicity symptoms were higher after the second dose, and no vaccine-related SAEs were reported. Next slide. This slide shows the immunogenicity and biosafety data and safety data reviewed by the workgroup for the Pfizer-BioNTech vaccine. Regarding the immunogenicity data, neutralizing antibodies were measured at 7 days post-dose 2, and again, the responses were similar to or exceeded the human convalescent panel. CD4 and CD8 T-cell responses were demonstrated, and a Th1 biased CD4 response was found. A 30 microgram dose of the BNT162b2 was selected for phase 3 clinical trials. Regarding the safety data, local and systemic symptoms were followed after administration. Fatigue, headache, and muscle pain were the most common symptoms reported, and reactogenicity symptoms were lower in the older population. Next slide. Both companies reported their plans for phase 3 clinical trials. Both are currently enrolling large phase 3 efficacy trials with goals of enrolling around 30,000 individuals. The primary efficacy endpoints for both trials are symptomatic virologically confirmed COVID-19 disease, and both vaccines are attempting to enroll diverse populations, which includes racial and ethnic diversity, as well as age and underlying medical conditions. Next slide. Both vaccine companies discussed the current cold chain requirements for their vaccine candidates. mRNA 1273 requires distribution and storage at -20, with around 7 days at 2 to 8 degrees. And BNT 162b2 requires distribution and storage at -70 with around 24 hours at 2 to 8 degrees. These requirements could be updated as additional studies are completed. Next slide. So overall, the work group thought the phase 1 data from both mRNA vaccine showed induction of neutralizing antibodies at 7 days post-dose 2 that exceeded levels in convalescent sera. And the data from both mRNA vaccines support advancing to large-scale phase 3 clinical trials to assess safety and efficacy. And the work group felt that the diverse cold chain or ultra-low temperature requirements could substantially affect implementation efforts. Next slide. The work group had several thoughts regarding the current phase 3 clinical trials. First, they emphasized the importance of enrolling diverse study participants. They also emphasized the need to allow for sufficient time post-dose 2 to evaluate safety signals in addition to the efficacy signals. And there is a need to report maternal and fetal outcomes for women who become pregnant during the clinical trials. And it would be helpful to evaluate the impact on viral shedding or transmission among both symptomatic and asymptomatic populations. Next slide. The work group also had thoughts regarding future or additional studies. First, regarding the need to evaluate co-administration of other vaccines, especially influenza vaccine, as well as studies in pregnant women and children if the initial trials are successful. Next slide. So next, moving to the work group interpretation of the EPI data. Next slide. The work group reviewed COVID-19 EPI among the US population, EPI among various occupational settings, and among individuals at increased risk for severe COVID disease. Next, I'll highlight a few of the important EPI points that influence the work group discussions. Next slide. First, as a reminder, the healthcare personnel definition is very broad, as essential workers who are paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. Next slide. And this was presented previously as the hospitalized healthcare personnel within COVIDNet, demonstrating the broad ranges of occupations for infected healthcare personnel. Next slide. This data presented previously regarding the workforce at long-term care facilities. On the right is the graph of cases among staff at skilled nursing facilities through mid-July. Long-term care facilities are disproportionately lower wage workers. Nearly 40% are 50 years of age and older, and nearly 80% are female, and a quarter are non-Hispanic Black persons. Staff can be shared among multiple facilities, and in many instances, COVID-19 activity increases among long-term care facility staff first, and then the residents. Next slide. Next, highlighting the data among workers in food processing and agriculture. Among 14 states from April to May, COVID was diagnosed in 9% of workers at meat and poultry processing plants. And among cases with race and ethnicity reported, nearly 90% occurred among racial or ethnic minorities. Outbreaks have been reported in many food production and agricultural sectors, and there are multiple factors that increase a worker's risk, with a few highlighted here, including prolonged close workplace contact with coworkers, shared transportation or congregate housing, and lack of paid sick leave. Next slide. In addition, the work group reviewed data on workers in correction and detention facilities. Staff members can introduce the virus through daily movements between the facility and the community. And in an analysis of 16 US prisons and jails, more than half of the facilities identified their first case of COVID among staff members. Next slide. And finally, the work group reviewed data on adults with increased risk for severe COVID disease that was presented earlier today. Accounting for the presence of individual underlying medical conditions, higher hospitalization rates were observed among adults 65 years of age and older. In addition, higher hospitalization rates were observed for adults with underlying medical conditions, as shown here, with obesity, chronic kidney disease, diabetes, and hypertension as some with the strongest association. Next slide. The work group also had presentations on modeling allocation strategies for the initial vaccine supply that were just shown to ACIP. 2 different models were shown, the overall population model and a nursing home model. Regarding the population model, similar numbers of infections were prevented by vaccinating healthcare personnel, essential workers, and adults with underlying medical conditions. Vaccinating older adults resulted in more modest declines in infection, but larger declines in deaths compared to the other groups. But overall, the differences in impact between vaccinating different groups was small. For the nursing home model, more infections and deaths were prevented by vaccinating healthcare personnel compared to vaccinating nursing home residents. So overall, the more infections prevented now through mitigation measures, the more impact the vaccine can have in the future. Next slide. Taking into account the epidemiology and modeling data that have been presented over the past several months, the work group discussed several important points. Many occupations deemed essential workers are at increased risk of COVID-19 disease, and the work group felt that it's important to consider these individuals who are unable to socially distance or work from home. Older adults, as well as adults with underlying medical conditions, are also at increased risk of severe COVID disease. And the work group noted that these groups are not mutually exclusive, that many essential workers are also older or have an underlying medical condition, also putting them at risk for severe COVID disease. And in many instances, cases increased first among staff in congregate settings, such as long-term care facilities or correction facilities. And the work group feels that it's possible that some protection could be provided to these vulnerable population by immunity among the staff and workers. Now we'll transition to Dr. Dooling, who will discuss how the data and work group thoughts can inform further discussions around allocation and distribution of the early vaccine doses.
Dr. Dooling, please.
Thank you. Good afternoon, everyone. Next slide. First, I'd like to ground the presentation in what the work group envisions as the overall goals of the COVID-19 vaccine program. First, to ensure that we have a safe and effective vaccine, that the vaccine reduces transmission, morbidity, and mortality of COVID-19 disease, that the vaccine program helps minimize disruption to society and the economy, including maintaining healthcare capacity, and that we ensure equity in vaccine allocation and distribution. Next. It's clear that identifying groups for allocation of initial doses of vaccine is critical for program planning at this juncture. I'd like to take a moment to call out at a high level all the areas of the vaccine system that will use this information. For example, we can strengthen vaccine distribution networks to reach target groups, and of course engage the key partners and stakeholders in order to accomplish that. We need to develop state and local microplans to develop communication strategies, and importantly, we need to enhance systems to rapidly monitor vaccine safety, effectiveness, and coverage. Next. It's likely that administration of COVID-19 vaccine will require a phased approach. Once a vaccine is approved for use, there will likely be insufficient vaccine to meet demand at first. There may also be cold chain storage and handling requirements that require specialized equipment and high throughput at clinics. Taken together, these call for a highly targeted administration in the first phase. In the second and third phases, we anticipate sufficient supply and a broadening of those implementation strategies. Next. However, today I'd like to focus the ACIP members on attention on the first phase, the period projected to be short that we may have limited administration limited doses and administration may be targeted. How can we best achieve the objectives of the program during this period? Next slide. To help your thinking about this period, here are some proposed scenarios for planning in the initial phase. It should be noted that these do not represent decisions, but are rather a tool to assist planning. In the first scenario, vaccine A demonstrates safety and efficacy, and there could be 20 to 30 million doses available by the end of December. If such a product needed to be shipped at minus 70 to minus 80 degrees Celsius and could be stored for only 24 hours at standard vaccine refrigeration temperatures of 2 to 8 degrees Celsius, this scenario would require shipping to large, adequately equipped administration sites with high throughput. In the second scenario, vaccine B demonstrates safety and efficacy, and there could be 15 million doses available by the end of December. This vaccine could be distributed at minus 20 degrees Celsius and stored for 7 days at 2 to 8 degrees Celsius. In scenario 3, both vaccines A and B demonstrate safety and efficacy, and doses would ramp up with potentially 35 to 45 million doses available by the end of December 2020. Next slide. Clearly, the planning needs are immense, and CDC, state, and local jurisdictions all over the country are actively working on plans. Although the implementation details are not the focus of this meeting, we can share some of the CDC activities to support implementation planning, including microplanning, critical populations focus, federal entity planning, development of IT tools, communication and engagement materials. Next slide. Departing now from implementation planning, I'd like to recap previous ACIP discussions regarding early phase COVID-19 vaccination. In June, ACIP expressed support for identification of groups for allocation of initial vaccine to aid implementation planning. ACIP recognized the disparity in COVID-19 vaccine impact on minority race and ethnic groups, essential workers, and low-income families. Also, attention was called to the need to build on existing vaccine infrastructure to meet the challenges of COVID-19 vaccination. In July, ACIP expressed support for healthcare personnel and other essential workers to receive initial vaccine allocation. Next slide. The objective of today's ACIP session is to focus on the work group's proposed groups for early phase vaccination. Those include healthcare personnel, essential workers, persons with high risk medical conditions, individuals, older adults over 65 and older. For each, we will describe the group, estimate the size of the group, and then consider the implementation challenges for all. We'd like to hear members' considerations for the sequence of the groups. During the September meeting of ACIP, a vote on interim allocation of initial doses is planned. Next slide. The first group I'd like to highlight are healthcare personnel. They were discussed extensively at the last ACIP meeting. Healthcare personnel are defined as paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious material. This includes persons not directly involved in patient care, but potentially exposed to infectious agents while working in a healthcare setting. The estimated population for this group is 17 to 20 million people in the United States. This estimate comes from the Bureau of Labor Statistics. Although not exhaustive, some examples include hospitals, long-term care facilities, which include assisted living facilities as well as skilled nursing facilities, outpatient, home health care, pharmacies, EMS, and public health. Next slide. Also shown during the July ACIP meeting, the composition of healthcare workers varies widely by setting, as you can see here in the comparison between hospitals and skilled nursing facilities. Next slide. Next, let's take a look at essential workers, other than healthcare personnel. CISA, within the Department of Homeland Security, is tasked with creating a list of workers who are essential to continue critical infrastructure and maintain services and functions Americans depend on daily. CISA has recently revised their list in the context of the evolving demands of the workplace during COVID-19. The guidance acknowledges that workers who cannot perform their duties remotely and must work in close proximity to others should be prioritized for mitigation measures. It's also important to recognize that subcategories of essential workers may be prioritized differently in different jurisdictions, depending on local needs. The estimated population for this group is approximately 60 to 80 million people, but it should be noted that this is a very rough estimate and may be revised as workplaces evolve and we find innovative ways to protect workers. Although not exhaustive, some examples include workers in industries such as food and agriculture, transportation, education, energy, water and wastewater, and law enforcement. Next slide. It's worth noting that healthcare personnel and essential worker composition by race and ethnicity is similar to the overall US population, according to self-reported data from the National Health Interview Survey. Next slide. Despite representation of Black and Hispanic essential workers that is similar to the overall population, a recent study from Utah demonstrated that Hispanic and non-white workers accounted for 73% of workplace outbreak-associated COVID-19 cases. The vertical axis you see here shows the industry sectors that have experienced workplace outbreaks. The dark blue marker shows the baseline industry percentage of Hispanic and non-white workers. The light blue marker shows the percentage of COVID-19 outbreak workers who are Hispanic and non-white. As you can see, in every industry, Hispanic and non-white workers have been disproportionately affected by workplace outbreaks. Next slide. Next, I'd like to highlight adults with medical conditions at higher risk for severe COVID-19. Earlier today, you saw details of the epidemiologic risks associated with these conditions. A systematic review indicates people of any age with the following conditions, listed alphabetically, are at increased risk for severe illness from COVID-19. The estimated population for this group is over 100 million adults. This is a rough estimate and may change as we gain evidence about the conditions which confer risk. From a nationally representative survey called BRFS, the percentage of adult population with selected medical conditions was estimated at 31% with obesity, 11% with diabetes, 7% with chronic obstructive pulmonary disease, 7% with heart condition, and 3% with chronic kidney disease. These are not mutually exclusive. Next slide. And the final group I'll highlight is adults who are 65 years of age and older. As you can see, the population pyramid here is in the millions of persons, and the overall group is estimated at approximately 53 million by 2019 US Census estimates. This accounts for approximately 16% of the US population. Of note, approximately 3 million persons currently live in long-term care facilities. Next slide. The proportion of the population with COVID-19 high-risk medical conditions is 33% among younger adults and 39% among older adults, according to self-reported data from the National Health Interview Survey. Next. So to summarize, these groups are clearly overlapping. There is significant heterogeneity between them and within them. And we are talking about a lot of people. This accounts for more than half of US adults. Therefore, there may be a need for additional subgrouping. Next slide. Now I'd like to transition to work group considerations, specifically work group thoughts on epidemiology, feasibility, equity, and ethics. Next slide. The work group has considered feasibility, including the implementation challenges and implications for distribution of initial vaccine. The following points summarize their input. A COVID-19 vaccine that requires distribution and storage at -20, followed by 7 days maximum at 2 to 8 degrees Celsius, will require diligent vaccine management to minimize waste. The storage, distribution, and handling requirements of a -70 vaccine will make it very difficult for community clinics and local pharmacies to store and administer such a vaccine. Ultimately, this will necessitate most vaccine be administered at centralized sites with adequate equipment and high throughput. Vaccinating healthcare personnel at centralized sites with high throughput is the best allocation of initial supply. Next slide. Workers at long-term care facilities remain a priority among healthcare personnel, and achieving high coverage is important and may be resource intensive. Mass vaccination clinics will be difficult to conduct in the setting of social distancing. Healthcare homes, such as provider offices or pharmacies, could be better suited to provide vaccination if recommendations are based on individual risk factors such as age or underlying medical conditions. The work group also noted challenges to equitable vaccine administration. These include, but are certainly not limited to, reaching people in rural areas, reaching racial and ethnic minorities, and reaching people with limited access to vaccines. Next slide. Clearly, as we consider groups for interim prioritization of initial vaccine supply, there are many unknowns. First, we don't yet know the vaccine performance, the magnitude of the benefits and potential risks, and importantly, if the vaccines are efficacious in older adults. We don't yet know if there will be multiple vaccines with differing profiles. We don't know yet the pathway to approval, whether that should be an emergency use authorization or full licensure. We don't yet know the timing of vaccine availability, nor do we know the number of doses available or the rate of scale up. And although we are working with unknowns and incomplete information, the work group remains committed to moving forward to help ACIP lay the groundwork for evidence-informed COVID-19 vaccine policy. Next slide. Next slide. To that end, I'll outline the next steps for the work group, and then, sorry, back one slide, I apologize. To that end, I'll outline the next steps for the work group and then return to questions for the ACIP. The next steps are to review clinical trial data for candidate vaccines as they become available, namely the safety data, including plans for post-approval vaccine surveillance, as well as immunogenicity and efficacy data, to review the epidemiologic data for risk of COVID-19 disease and severity by race and ethnicity, and you'll see that at the next ACIP meeting. Review results of focus groups and other public engagement regarding COVID-19 vaccines, and also to review equity frameworks for allocating vaccine. Next slide. And in that vein, authors at the Johns Hopkins Bloomberg School of Public Health recently released an interim framework for COVID-19 vaccine allocation and distribution in the United States. I'd like to specifically call out that Tier 1 groups within their framework are described as those most essential in sustaining the ongoing COVID-19 response, those at increased risk for severe illness and death, plus their caregivers, and those most essential to maintain core society functions. The work group will be considering this framework as well as that which is forthcoming from the National Academy of Sciences, Engineering, and Medicine. Next slide. We now have some questions for ACIP input. Given the information presented thus far, including the epidemiology, the values, acceptability, feasibility that you've heard about, do you agree that initial doses of COVID-19 vaccine should be allocated to healthcare personnel? I'll pause there before going on to the next question.
We'll open it up to comments, please. Dr. Maldonado, I see that your hand is up. Oh, it must be a leftover, sorry, thank you. Dr. Atmar.
Thank you. So I have a question, and then I'll try and answer your first question. My question is, has the work group considered regional distribution of vaccine based on or guided by local prevalence of disease? You know, based on where the virus is circulating, where it's been more or less controlled through other public health interventions, being guided by that epidemiologic information.
Right, I'll answer that before you go on to your response to our first question. But the work group has considered that to some extent, and also discussion of outbreak, vaccine allocation in an outbreak setting. And some of the factors that were discussed included the fact that all of the early vaccines candidates in development are 2 doses. Thus, the amount of protection that's conferred before the several weeks following the second dose administration is unknown. So the timing may not be adequate to really combat active outbreaks. The second is, there are still unknowns with regard to what the underlying seroprevalence of any jurisdiction will be at the time, and ultimately how long-lasting that protection is that we're testing by way of seroprevalence studies. So those are just some of the factors that have been brought up in that context when we think about allocation differential by disease rates.
Thank you. So to a certain degree, I'm worried that my answer and the answers of many on the panel may seem self-serving since we're all healthcare personnel. You know, it's hard based on the risk stratification that you gave to pick one group over another, and it really sounds like the guiding principle may be the implementation. And I would agree that the healthcare industry is probably in a better position to handle and distribute the vaccine to healthcare personnel in those circumstances that you outlined, should it be one of the candidate vaccines that has those difficult cold chain issues to address. Over.
Dr. Cohn, please.
Thanks. This is Dr. Cohn. I just want to add to Dr. Dooling's presentation and Dr. Artmar's comment that when you look at the number of doses that may be available early, in that very early constrained period, we would propose that you would actually half those numbers of individuals that should be vaccinated because of the short timeline between doses 1 and 2 being 21 and 28 days. If doses are being released, we want to make sure that individuals receive both doses and we don't vaccinate more broadly and then not have doses made available the following month, for example, to provide people second doses in those windows. So there's some additional considerations around the total number of individuals that may be vaccinated over time as well.
Dr. Szilagyi.
Yeah, thank you. And Dr. Dooling, thank you, as always, for a wonderfully clear presentation. I'll go out on a limb as well. And I was going to go where Dr. Antmar was in terms of both somewhat of a dilemma about feeling self-serving because we're healthcare personnel, but really focusing on implementation issues in addition to the cold chain. I mean, I'm struggling with, I don't really know how many doses there really will be. And Dr. Cohen, I understand the issue about the 2 doses. But if there will only be 20 million doses, then how would we allocate vaccine within the other groups, which are much larger, 100 million, 50 million, 60, 80 million? Secondly, I do think that there is a challenge with confidence in this vaccine because of a number of different reasons that we have all discussed. And even greater, there's some evidence now that very high-risk populations, including some minority populations, may have more concerns about the future vaccine than other populations. My sense is that healthcare personnel, although I've been hearing anecdotes about concerns about the vaccine, my sense is that the uptake among healthcare personnel would be much higher. And so that could start kind of a nice process toward increasing confidence toward the vaccine if we get it ourselves and if the proportion of healthcare personnel who are vaccinated is very high, particularly when there's an issue of concern about confidence in the vaccine. Kind of doing it ourselves is a very good demonstration, I think, for the rest of the country. And the other point I was going to make is back to the point about how many doses there might be. I'm almost wondering whether we may need to think about prioritizing within these conditions if there are fewer doses. In other words, the circle of available doses is much smaller than the circles that are on this slide. Thank you.
So I'll take this opportunity to offer my comments. And I think they echo those which have already been stated. The issue that stands out most in my mind is the issue of storage, transmission of the vaccine, these requirements for ultra-cold storage and transmission. In a state like mine, which is primarily rural, this poses a significant problem. It, without a doubt, means that we're going to have to focus on healthcare personnel initially, and to really reach other populations, our high-risk essential workers, such as meat packers, agricultural workers. They may have to wait until we have a more stable vaccine that can be transported and delivered more or less at room temperature. So I see that as a big issue here, one that is maybe out of our control because of the vaccines that are available. I also think that there should be some degree of flexibility in determining these risk groups based on the limited supply within each state. So my risk group assessment, and I'm just using me as a person, I mean our risk group assessment, may be a little bit different than that of the work group or the ACIP. So there should be allowed some flexibility in that area, I think overall, not to vary significantly, but that there should be some flexibility. Lastly, two comments. The issue of lab personnel, whether they not specifically in the hospital, but in commercial laboratories that are carrying forward the diagnostics of COVID. We as public health officials suffer greatly when we cannot have rapid turnaround of diagnostic tests, either because of supply or because of personnel not able to process those. My public health lab, if it suffered a significant hit from COVID, would be a major blow to our effort of COVID detection and containment mitigation within the state. So I think it's very important that within that healthcare group, you include not just laboratoricians within the hospital system, but public health and commercial. And lastly, the issue of public health workers. So public health workers are essential to my state in control and mitigation of outbreaks. We send them out into the community to find these individuals, test these individuals, make recommendations. And unfortunately, I have had several of my public health employees become infected. So I would like to put that out there and champion that cause also.
And this is Dr. Cohen. I just want to provide a clarifying statement on behalf of Dr. Romero. He is speaking in his new role as the State Health Officer for the state of Arkansas. So he is now officially a member of the public health community.
And I thank the public health community for taking me in. Thank you. Ms. Bata.
It certainly seems clear that in some of the modeling, there is a benefit both to the healthcare community and the population that they care for, especially in long-term care facilities, by vaccinating those healthcare workers. And as I've thought about this and read through the Johns Hopkins document, it seems that we really need to be able to continue to provide care to our broader population who will require hospitalization, and without having a huge compromise of our healthcare population being ill. I know in Minnesota we saw many of our long-term care facility healthcare workers ill with COVID-19 this spring. And a lot of it was because of lack of PPE, but that seems to be going to be, as far as I understand, a persistent issue of obtaining adequate amounts of PPE for our healthcare workers. And so in that respect, I can really support an allocation to our healthcare personnel.
Dr. Lee.
Thanks so much. Sorry, there's an echo still. Thank you for summarizing the work group perspectives. It's been a really challenging set of discussions for so many reasons. I did want to maybe state that, first of all, I do think that the sort of distinction between where we want to be in 6 to 9 months versus where we are today is really important, in part because, of course, benefit-risk balance is going to be critical to all of our decision-making. But in the first, weeks of vaccines being available, implementation considerations are going to be huge. And do agree that given the current vaccine candidates that we think, hope might come forward on the earlier side, that it would make sense for us to really make sure that we're reducing the complexity of implementation as much as it's feasible. The more complex we make it up front, the harder it's going to be for us to then scale up quickly. So I do think that I am supportive of this idea of prioritizing populations where we can actually implement the vaccine, assuming, again, excellent benefit-risk balance in our favor. I had one question, which is, I wonder if anyone on the phone would be able to comment on other potential vaccine candidates that were mentioned early on. I'm thinking specifically there were 2 that were supposed to initiate trials later on, what the timing of that might be. Just because I think that could be helpful for our decision-making early on as well. And I think they were Novavax and the Oxford vaccine. Maybe I'll stop there for a second. And I think I have one more comment.
This is Kathleen Dooling. I can respond that we are in communication with all of the companies that have plans to enroll candidates and do clinical trials in the United States, and the work group will hear from them, and then subsequently they will have an opportunity to present at ACIP.
You had another comment, Dr. Lee?
Yeah, thank you. Just really quickly, thinking about the fact that Dr. Szilagyi mentioned that if we do have a really limited supply of vaccine in the early weeks, it will behoove us to make sure that we're using data to drive decision making. Obviously, we want flexibility at the local level to make sure that each local area understands the epidemiology of their disease and is getting it to those workers that really seem to have a high risk of exposure, and that will differ by region or by sort of local context. So I think providing the guidance around this, yet allowing and ensuring that people are using data to drive that decision making will be really important for us. Thank you.
Dr. Hunter.
Thanks. I just want to start by saying that I want to thank all the speakers today and over the 4 years that I've been on ACIP for serving up just on a silver platter the kind of information we voting members need to give input. So I just want to be very appreciative of that. I agree that starting with healthcare personnel will prevent a large number of infections and deaths as much or more than other priority groups. So that makes sense starting with them. I think that the implementation issues like vaccinating healthcare personnel being able to be done at facilities that are most likely to implement the specialized storage and handling is a plus from an implementation point of view. In addition, I have some personal things that I'd like to advocate for from my perspective as a clinician and a public health person. Welcome to public health, Jose. And that's first one of those is I think in order to promote vaccine confidence, I would advocate for ACIP policy statements that encourage vaccination to be voluntary and not a condition of employment. I would also support policy statements that allow some flexibility in interpreting eligibility for vaccination at the point of administration or registration, especially as the vaccine supplies increase. Obviously, early on, that's going to be going to need to be tight, but I think that we need to prepare from the beginning for that transition between those first of the three phases, outside of the red circle into the time when we're going to have more, hopefully, vaccines. So that's my comments, and thanks again for all the wonderful information.
Thanks, Dr. Atmar. This is Amanda. I just want to build off of your one comment and remind the committee members that while many healthcare workers will be able to be vaccinated with more easily, given that they are at healthcare facilities, there are a number of healthcare workers who work at long-term care facilities or other and in other places that we will still have to ensure access to vaccination if indeed that is the first group. Going back to Dr. Slayton's presentation, clearly long-term care facility staff will be an important group as well. Dr. Lee, Dr. Romero had to step out for a minute, so I'm going to take over. Dr. Lee?
I apologize.
Dr. Hunter? Oh, Ms. McNally.
Yes, thank you. Speaking as the consumer representative for really the reasons that have been discussed, and in particular the risk associated with healthcare personnel in COVID-19, the implementation that's been discussed, as well as the potential for safety monitoring, I also would express support for prioritization for healthcare personnel.
Dr. Dries?
Yes, I just wanted to comment on the comment from a few minutes ago about making the vaccine of employment. And I'm not necessarily asking that we do that, but it does affect comp. If a vaccine is required for employment and there's an adverse effect, that is automatically covered by workers' comp. Whereas if it's an optional vaccine, it is not necessarily covered. Although an institution can choose to cover that. So that we just might want to think through kind of the language around that and making sure that any adverse effects that do happen are covered. Thank you.
Dr. Atmar, I saw your hand was up. Did you want to overcome?
I took it down, I put it up again. I wanted to reply to Dr. Hunter's comment about not making it mandatory. I don't know about other states, but here in the state of Texas, there is a law that basically says that healthcare practitioners, personnel, need to take or be vaccinated against vaccine-preventable diseases, with a few exceptions. So we may make suggestions, but some of this is going to be guided by local laws and other considerations.
Dr. Cohn.
I just wanted to add to that. Just wanted to remind everybody that under an emergency use authorization in EUA, vaccines are not allowed to be mandatory. So early in this vaccination phase, individuals will have to be consented, and they won't be able to be mandated.
We didn't clarify whether this is going to be under EUA or licensure. That was an open question. So, but thanks for that clarification.
I don't want to cut off discussion, but we do have other questions. I have two people on that want to ask or make a comment. Dr. Bell first, followed by Dr. Hunter.
That's okay. I'll wait till we're about to wrap up.
Thank you, Dr. Bell. Dr. Hunter?
Yeah, just a quick clarification of my previous comments. I didn't suggest that. I guess what I was suggesting is that our ACIP recommendations are sort of a base. It's sort of like a federal law, or where you have a base of the minimum that you can do, and then local or state can do more with a federal law. And I sort of see that the same way, in my opinion, about how to deal with requiring it for employment, which is we wouldn't say that we are saying it has to be required for employment, but that that would could be a consideration that you could require it for employment. And here's in the guidance, here's some advantages and disadvantages to that, I guess, is the way I was, just to give a little more nuance to my previous comments. Thanks.
Thank you all. So we'll move on now to the next question. Dr. Dooling.
The second question for ACIP members is, if vaccine supply remains constrained due to either vaccine or distribution limitations, do you agree with vaccinating essential workers next as supply permits?
Dr. Hunter, your hand is up. Is it left over from the previous question?
Yep, still left over.
Dr. Bernstein.
Maybe you can remind me, when you were in discussing the modeling allocation strategies, and you talked about different assumptions regarding VE, how was acceptance of vaccine by these specific populations factored in? If we were talking healthcare personnel, did we look at it at 75% acceptance, 50% acceptance, 25% acceptance, and the same with the other groups? And building confidence into that is very important.
I can speak to my understanding of the modeling results, and if Dr. Slayton's on the line, she can correct me if I'm wrong, but the models did not factor in a partial acceptance. They modeled X number of doses going entirely to certain groups, and then let the model results play out.
As I would expect that each of these populations, the percentage of individuals that would accept these vaccines could be quite variable by population as well as geographically.
Dr. Atmar.
So I'll bite, and I will agree with the assessment that essential workers would be the next target to basically help maintain society's infrastructure. Over.
Dr. Paling.
All right. Thank you. I wanted to add to this conversation because I do agree that the data that has been presented to date highlights the importance of covering the healthcare personnel followed by the essential workers. And the implementation is a really important component of things because the more that it is reliably in the population with full protection, meaning both doses. And so the microplanning and all that going on is really essential because implementation in cold storage will remain an important part of this consideration.
Dr. Sanchez.
Sorry, I'm mute. I agree to a point, but I think that the high-risk medical conditions really, so that would, in other words, that would be next. And I don't know if maybe within the essential workers prioritizing first high medical conditions, because obviously it's a huge number that vaccine may not be available for all. But the high-risk medical conditions are associated with more severe disease and death. And I think that we need to prioritize some of that as well.
Thank you. Dr. Szilagyi.
Sorry, I was on mute. I'm struggling with this one. The size of the essential workers is about the same as the older population, and essential workers, if the model is correct that we saw before, would save far fewer deaths, but they're essential workers, and that's critical for societal operation. So I'm kind of struggling with all of these three circles, which is obviously why you asked us to comment. I do want to point out that with minorities having substantially higher risks from COVID and morbidity and deaths from COVID, and many of them being essential workers, I think, as well as many of them having high risk medical conditions, I think, in a sense, targeting essential workers targets a very high minority population that is obviously essential because of their occupation. So I could certainly go along with this, but I'm struggling. And I can't remember what the overlap is between essential workers and high-risk medical conditions. Does it look like these circles, or is there a greater overlap? I also think it would be potentially possibly easier to administer the vaccine with the cold chain, especially if there are sort of mobile vans or other ways of getting to the essential workers. Thank you.
Dr. Fry.
Thank you. I had a quick comment, but really more of a question. So far I agree with both of these groups as being prioritized, but I think there has to be a strategy within the groups to prioritize people within the group, of each of these groups. But my question is, and I think Dr. Lee alluded to this earlier, who makes the decision about how many doses go to a particular region or state? And then within that region or state, who distributes or will prioritize who is supposed to get vaccine? In other words, does the federal government say, okay, region 1 gets X number of doses, and region 1, you figure out who within that region is going to receive these doses? How does this allocation occur once you settle on who's going to be vaccinated?
So Dr. Messonnier will offer comment.
Yeah, thank you. That's a really important issue. And my response is not as succinct as I like to give ACIP when they ask these hard questions. I think that that's still an issue that is under discussion, and there is a complicated interplay between the question of prioritization and allocation. In other words, one might want general information about the question you posed before you make decisions about prioritization, but we think that the way this is going to go is that once we have ACIP's recommendations around prioritization, and once we have more information about the specific characteristics of the conditions of use of the vaccine, the federal government will be in a better position to make allocation decisions. And from a CDC perspective, we're working up the technical specifications that would go with a variety of potential scenarios. What I would also say is that for folks who have been through H1N1, which is very different but has certainly similarities, I hear some of the same sentiment that Dr. Romero echoed earlier in this session, which is to ask us not to try to over-engineer and to leave space for state and local health departments to do some, leave state and local health departments some flexibility to deal with their own local situations. And so we definitely have heard that input, and we'll try to take it into account in our proposals.
Thank you.
Unless there is substantial objection by the voting members, I'd like to take two more persons for questions or comments, and then move on to the public comment session. So if you have objection, raise your hand. And in the meantime, Dr. Lee, please go forward.
Thank you. I'll try and be quick. With regard to number 2, I'm also struggling with it. It's hard to make this decision yet until, it's assuming that the implementation considerations that we know about today are going to be the same 4 weeks from now. So I just want to acknowledge that I think, deciding, whether it's essential workers or those with high-risk medical conditions, to me is really challenging. And I think we'll just have to see where we are in a few weeks with regard to understanding more about implementation challenges, and again, getting a sense of which vaccine candidates might be the most likely to come forward initially. I did want to say that within the groups, there is, obviously, and Dr. Masonier alluded to this, the ability to acknowledge that there are differential risks among even low-wage workers within the healthcare delivery system, those with high-risk medical conditions and age. But that kind of guidance, even within a particular category, I think should not impair implementation efforts. And we do need to acknowledge that risk-based recommendations are always more challenging to implement, COVID notwithstanding, than universal recommendations. So I think providing enough information that local teams who are doing the vaccinating can actually make sure that they are maximizing the impact, but also not constraining them so much that they're not getting the vaccine out there. I think that's the balance we'll need to strike. Thank you.
Dr. Talbot.
Yeah, so I want to remind everyone that we're in a weird time, and that we have people who still have to go to work and put themselves at risk. And there are many with high-risk conditions that can work from home, but there are many with high-risk conditions who are essential workers and who are putting their lives on the line to keep our society running. So I think it's absolutely critical that we continue to think about the essential workers for many reasons. One is because they are of lower, many are of lower socioeconomic status, many have high-risk conditions, and they are unable to work from home. So I think that's the key. As vaccine becomes available in huge quantities, then we can talk about the people who have the luxury of staying at home. And I think along those lines, too, is we won't have enough vaccine for everyone in healthcare and then everyone who's an essential worker. But I think you also have to remember not everyone's going to want the vaccine. We have the opportunity to offer it to these first, but not everyone's going to take it up. And maybe, too, with a limited supply, some people will be more motivated to get it. I think as for the freezer comments, there are some amazingly talented and innovative people in our health departments and at the CDC and in public health. And I think they will come up with incredible ways to get to our essential workers. So I don't want that to limit us. I think we should continue to think about our essential workers and then just get really creative. Over.
So it's getting time that we move on, but in deference to the chair of the work group committee, Dr. Bell, would you please offer the final comment in this session?
Thank you, Dr. Romero, and that's what I wanted to do. I just want to thank all of my colleagues on the ACIP for such thoughtful and helpful feedback to us on the work group as we move forward in an effort to make interim recommendations for planning purposes, which is clearly going to be pivotal to any successful vaccination program. With all of the moving parts, all of the uncertainties, as I say, I just want to thank people, and I've been struck by how much the ACIP members have stuck with the guiding principles, and as I say, also provided us with some feedback and food for thought so that we can work through these issues further between now and our next meeting. So thank you to everyone.
Thank you all in the work group for having offered those comments that were thoughtful, insightful, and will guide us in future discussions. And thank all of the CDC work team that has put this together.